presentation of our keynote speaker, Professor Cletus Aguwa. And sir, please could you be standing, sir? Thank you, sir. Professor Cletus Nzebunwa Aguwa, FPSN, FPCPharm. He's from the legendary Aguwa family in Abo Mbese, LGA, local government area of Imo State. From 1960 to 65, with the Eastern Nigeria Regional Scholarship, he received secondary and higher school education at Holy Ghost College, Owerri, and Trinity High School, Oguta, respectively, in the mid-1960s. He then proceeded to the prestigious Howard University and later to the Philadelphia College of Pharmacy and Sciences in the United States of America, where he was educated and trained as a clinical pharmacist. In 1978, Professor Aguwa returned to Nigeria and was the first clinical pharmacist to be employed in any Nigerian university. I think that's a good place to clap. Before returning to Nigeria, Professor Aguwa was assistant professor of clinical pharmacy at Howard University College of Pharmacy and Pharmaceutical Sciences, Washington, D.C. from 1974 to 1978. He was a registered pharmacist in Philadelphia, Maryland, and Washington, D.C. In Nigeria, and specifically at the University of Nigeria, Nsuka, where he spent most of his life as an academic, he has had a fairly good academic and professional career, rising through the ranks and becoming a professor in 1987. He has held many positions in the University of Nigeria, Nsuka, including head of department, associate dean, chairman board of governors of the University of Nigeria Secondary School, pioneer director, University of Nigeria Community Bank, to mention a few. From 1988 to 1990, he was a visiting professor of clinical pharmacy at the King Saud University and clinical pharmacist consultant at King Khalid Teaching Hospital, both in Saudi Arabia. Professor Aguwa is the pioneer of clinical pharmacy in Nigeria and its first professor. He, on assumption of duty at Nsuka in the Department of Pharmacology and Toxicology, as we know, there was no clinical pharmacy for him to head at the time. He introduced clinical courses at UNN. In 1991, he put clinical pharmacy into practice for the first time in Nigeria by taking final year students to hospital wards. In 1992, as dean and member of the Pharmacists Board of Nigeria, he led a delegation of deans to some pharmacy and hospital institutions, including Howard University in Washington, D.C. and Philadelphia College of Pharmacy, to let the deans have hands-on experience of clinical pharmacy practice. In 1998, during his second term as dean, he established a full department of clinical pharmacy and pharmacy management in the Faculty of Pharmaceutical Sciences and UNN. Professor Aguwa is a member of many professional associations, including Roche Pharmacy Honor Society USA, American Society of Hospital Pharmacists, Academy of General Practice Pharmacy. One moment. Academy of General Pharmacy Practice, Pharmacy, American Pharmaceutical Association, Pharmaceutical Society of Nigeria, National Pharmacists in Academia, to mention but a few. He has received various awards, including the Fellowship of the Pharmaceutical Society of Nigeria, Fellowship of the West African Postgraduate College of Pharmacists, Special Award as a Distinguished Academy in the Faculty of Pharmacy by the Alumni Association. Professor Aguwa has over 70 peer-reviewed published articles to his name. He has also written and edited many books, including The Making of Clinical Pharmacy in Nigeria. Following his full retirement from UNN, Professor Aguwa was drafted to Madonna University, Elele, where he is currently the Dean of Pharmacy. Although Professor Aguwa spent most of his life in universities and especially in Nsuka, he is an Mbese man to the core. He was the chairman of Izu Mbese, Nsuka, for over 10 years. He is patron of Mbese Association, Nsuka. Mbese, all right, thank you. Mbese, apologies to all the Mbese men and women in this hall. So, he was chairman of Izu Mbese Nsuka for over 10 years and patron of Mbise Association Nsuka and Nguru Development Union Nsuka. He is a member of Council of Ezurezu Mbise and others, and offers financial and moral support to the association. He is a Roman Catholic and is happily married to Mrs. Loreto Aguwa, and they are blessed with 5 children, all of whom are graduates, one a pharmacist. Please join me as we welcome to the podium Professor Cletus Aguwa to deliver the keynote address. You're very welcome, sir.
Let's keep those hands jamming for Professor C.N. Aguwa. I can see the smile on people's faces. Thank you. You're welcome, sir. I have to observe all other protocols. If I had known that such could have been said about me, maybe I would have written my speech in a different way. Thank you, presenter, for nice things you have said about me. Looking at the galaxy of pharmacists here, most of them who have gone through me, I feel very much humbled. And I'm quite honored to stand before you. But before I make my speech, I would like us to know who we are in the society. Yes, we are pharmacists. The question is, how tall and strong do we stand in among the health professionals? And how does society appreciate pharmacists? I would like to remind us that the function of the pharmacist is to offer service to the public, especially those who are sick, to treat, prevent, and cure diseases. Majority of the sick in the society first report to the pharmacy for help for all types of illness. Pharmacists are regarded as the most scientifically educated health professional. Pharmacists are most honest. And these statements are based on studies. And pharmacists among the health profession are the least to commit suicide. And on that note, I congratulate you, and I am proud to be a pharmacist. Even though it appears that somebody has x-rayed what I was going to say, it is important that at times when people speak, you know on what basis and what background are they laying their claims. And it appears some of those things have been stated about me. But let me state that it's true I went to US, studied in 2 universities, had my clinical experience in 3 hospitals in Philadelphia, and I went to Howard University to teach as assistant professor of clinical pharmacy before I returned to Nigeria. Within a short period of time, I spent my time at Saudi Arabia, which was a mission. But as you mentioned about my background, I could tell you that as I arrived in Nigeria, Nsuka, in the 1970s, I did not know that I was the first academic clinical pharmacist to be employed in Nigeria or in any Nigerian university.
Thank you.
The pharmacy unit at that time was a sub-department in the Faculty of Biological Sciences. And there were a few Nigerians, Egyptians, and Indians who were handling the department. These Nigerians were few in number, but they were determined to set up the clinical pharmacy following the interruption by the Civil War, the Biafran Civil War. They determined that the Faculty of Pharmacy should be instituted. Now, the task was a little bit heavy. On my arrival in this sub-department to prepare and set up competent, objective teaching method. But this opportunity or this situation, this haphazard situation, offered me the opportunity as the pathfinder to introduce both biological and clinical courses in the faculty curriculum. Few years later, pharmacy sub-department became a faculty with academic staff employed, and I was appointed as chairman of the curriculum committee. With this position, many staff didn't agree with the way I was introducing clinical courses. But being a lone voice in the wilderness, I continue to preach the concept of clinical pharmacy. Is this American guy? Why? Why all this pathology, anatomy, and disease tests? Is he going to make us pharmacists or many doctors or many nurses? That's what they asked me, which I did not give the answer. Later on, some of my colleagues from university, from AB University, led Dr. Odutola, pharmacist Geoffrey Obiaka of UBT of ABUTH, my friend sitting in front of me, Dr. Ariba Osula of Benin, and one Dr. Justin Omwok, who is not here with us. These people from other universities supported the introduction of clinical courses in all pharmacy curriculum in Nigeria. The rest is history, as I publish it in my small book, The Making of Clinical Pharmacy in Nigeria. From clinical courses to Department of Clinical Pharmacy in Nigeria, then from 5 years B.Pharm degree, now to 6-year degree. This is a major development in the pharmacy education in Nigeria, which Pharmacists Council of Nigeria has strongly supported. Let me make a little shift from what we are talking about. Let's look at the global village. There were many predictions into the 21st century. There were wars in Asia, Europe, Africa. There were nuclear accidents and earthquakes. There were too many philosophical theories that governed the world, but at last, socialism gave way to capitalism. The Berlin Wall was destroyed, and this resulted to an era of superpower. Technological advances with the development of computers and internet communication waves have dramatically changed the rate and the way things are done. Yet, as global village grows, we expect much more to happen in the non-stagnant world. In the health sector, the world has been ravaged by many diseases, resulting in human suffering and death. The WHO took a bold health action to declare health for all by the year 2000. This yielded impressive results in some areas. The EPI was effective, death in children due to the area was drastically reduced, smallpox was eliminated, but malaria, filariasis, HIV infections, AIDS, heart disease, cancer, tuberculosis, and many others still persist. Of recent, the whole world embarrassed by COVID-19, and we are still struggling to completely eliminate it. Unprecedented earthquake destroyed many lives and infrastructure in two countries of Syria and Turkey. How can we continue, not to mention the Russia-Ukraine war that is taking many lives and destructions? And the question is, what does that mean to pharmacists? Drugs are essential for pharmaceutical care. Many drugs were discovered during the last century, and many more are being added to the health armamentarium.
Yes, you travel before
Calcium
me.
channel blockers, ACE inhibitors, beta blockers, H2 receptor blockers, proton pump inhibitors were drugs of yesteryear. And of recent are many new drugs to fight against all types of diseases. Significant inroads have been made in vaccine development, the treatment of malaria, COVID, and AIDS. Biotechnology and genetic engineering hold promise for many new changes and innovations in the near future. The fundamental challenge to pharmacy today is to translate pharmacy purpose and professional destiny into a renewed commitment to patients' welfare with this new development in the pharmaceutical industry. The profession's practitioner must be inspired to action which pursue the goal of qualitative drug supply and rational drug use, both for prevention and treatment of ailments. The implications are that all the building blocks of pharmacy, including educational, legal, regulatory support, professional organization, administration of practice, and the individual pharmacist ethical bearing must be brought to bear in fulfilling pharmacist's role in healthcare now and in the future. I want to make a comment about pharmacy education in Nigeria. And I have to say that we have made giant advancement in Nigeria with respect to pharmacy education. The curriculum has been severally updated with many biological, pharmaceutical sciences in the 5-year program. With the arrival of clinical courses, the pharmacy program has been upgraded to 6 years. One could observe that many basic biological courses have given way to clinical courses with the hope of introducing clinical practice. What this may mean to educators and students alike is that training may predominate and the education is the secondary outcome of pharmacy education. The curriculum is overloaded. Can the students carry them? The issue is whether we have reached the point of overtraining and undereducating the students. Now, to educate implies development of varying degrees of growth and expansion of knowledge. To train involves to teach in and out of profession with specific skills. That is to say that where education concentrates on intellectual development, training centers more on skills and competence development. In a 6-year program in pharmacy, we have to address the issue of over-educating versus over-training. And we are at present over-training our students for practice at expense of their intellectual growth. And if so, we are narrowing the ability to adapt to new changes that are currently would be foreseeable in the future. The PCN has supported that all the schools of pharmacy must adopt the 6-year program before 2023. Time has been given to implement this policy, but we are ready. Are we ready to implement this program with 6 years? The infrastructure is not adequate. Many schools of pharmacy do not have complement of staff. Most part-time and retired professors are on contract. And technical and laboratory staff are not available. Pharmacy education, that is laboratory intensive, is now more or less in didactic presentation. Students do not have required text for courses, and the use of smartphones cannot be equivalent to learning from the textbook. And with part-time lecturers and some retired contract professors, it is difficult to get complement of staff in any department that can steadily impact the pharmacy education on a regular basis. Thus, lectures are in haphazard way, and laboratory intensive programs are now administered in all courses by what is called alternative to practicals. If pharmacy education is administered with alternative to practical, what of other areas that are non-science based? Let me comment on clinical pharmacy. You want me to say something about that? Yes. I think members of CPAN committee, they know me well enough to appreciate that I am well positioned to speak on the present subject in clinical pharmacy practice in Nigeria. As the teacher practitioner who has emphasized clinical function practice and in the academic area, and to prepare future graduates for clinical pharmacy practice, I feel I have more than a casual interest in the subject, and I can speak from a base of experience. Majority of what I state here are some of my personal experiences, programs that I have participated to develop or implemented, and how I view pharmacy should practice in Nigeria. It is necessary from the start for me to clarify some terms. One, clinical pharmacy, clinical pharmacists, clinical pharmacy practice, clinical practice, and patient care. These are terms that we are using. Sometimes we get them all mixed up. Traditionally, gentlemen, pharmacy practice deal with patients. Therefore, clinical pharmacy and clinical pharmacy practice are synonymous with pharmacy and pharmacy practice. Some functions may be more clinical than the other, but by its nature, all pharmacy practice are clinical. And therefore, all pharmacists in Nigeria are clinical pharmacists. Pharmacists in Nigeria, especially those in the rural areas, provide primary health care. Provision of primary health care service involves diagnosis, prescribing, and in some cases, administration of medicinal products to patients. Almost all healthcare centers in the country are run by healthcare nurses. And it is reasonable to expect that pharmacists should have been in charge since drugs are heavily utilized in the treatment. Clinical pharmacy is defined as the health science specialty which embodies the application by pharmacists of the scientific principles of pharmacology, toxicology, pharmacokinetics, and therapies in the care of patients. A clinical pharmacist is defined as a pharmacy graduate with advanced pharmaceutical and biomedical education and extensive clinical training, who practice clinical pharmacy as his major professional activity. The emphasis on this definition is based on acquisition of advanced knowledge in the pharmaceutical and biochemical sciences, coupled with extensive clinical experience. Clinical pharmacy, therefore, can be practiced in any healthcare setting, and those wishing to retain practice skills should be engaged primarily in clinical activities. Some areas of specialization have emerged, thus clinical pharmacy generalists and pharmacotherapy specialists. The difference may be the healthcare setting and the level of performance by the pharmacist. The most important criteria that distinguishes a specialist from the clinical pharmacy generalist is the level and complexity of decision-making. How simple is the decision? How complex is it? On what basis that you make a decision? That's what makes a lot of difference. Patient's care may involve simple or complex process that members of the healthcare team may employ to restore normal health to a patient who presents himself to their healthcare facility. This process may involve diagnostic, therapeutic, physical, and psychological needs of the patient. Most of the time, pharmacists offer several pharmaceutical services that complement those of the physician and nurse to improve patient care. Having said that all of us are clinical pharmacists, let me comment on community clinical practice. We know the tripod of healthcare, but we must admit that the real primary care providers are who? Our mothers, our fathers, the families, and the patient themselves. They're really primary. Healthcare and maintenance of good health is basically lay function, with professional services as supplementary resources. Most people here don't just run to a doctor. If you have some pain, you do something, your mother or your father or somebody, educator will advise you do this and do that before you start going to do MRI, doing X-ray and all that. Those are unnecessary or supplementary to your primary care, which your mother or your father could offer to you. No wonder then there's a book titled Where There Is No Doctor. And this book, some of you have read it, is found to be very, very useful, Where There's No Doctor. So community clinical practice exists in Nigeria, but it is not organized with respect to the cooperation with other members of the health care team. When a pharmacist renders health service, while giving advice or educating on a proper use of drugs, no one pays for it. It is a professional service. The patients who know the cost of the drugs will only pay for that cost, since he does not call it professional fee. It is likely and proper that the patient may get much better improved from what the pharmacist told him, but at the same time, the pharmacist may make less sales following his recommendations. So the community clinical pharmacist is particularly well qualified and available without appointments to advise on the use of and monitor drug effects or all the drugs over the counter. Most physicians dispense medications without label so that the patient or community pharmacist will not know the names of the drugs. This is a technique of ensuring that the patient returns to the clinic when the drugs finish. And this practice also has some disadvantages. Because in case of allergy or an accident or emergency, nobody else, if the doctor is not around, knows what the doctor has written. And this can endanger the life of the patient. So these are certain things that have to do with our community. There's no cooperation. We are not aligning ourselves with other health professionals. Now, if you come to institutional or assistant clinical practice, you find that the hospital setting is the better site for clinical practice, as it is easier for the clinical pharmacist to be integral member of the health team. As a member of the team, the hospital program should include the pharmacist and outline activities they should do. It is the responsibility of the hospital pharmacy department to outline these activities and have them accepted by the hospital administration. His roles should be strictly related to his professional skills and competencies and be important enough to justify the cost of additional personnel in the healthcare team. He should be outlined. He should be properly outlined how some of these functions should be performed, as they may vary from one institution to the other. Example, are there situations when a clinical pharmacist could prescribe some drugs or offer discharge counseling or advise the patient when next to visit the clinic? Clinical pharmacists should be involved in research involving pharmacotherapy in the hospital. But if we X-ray our hospitals nationwide, we observe that most of them are not ready to offer clinical services as it should be. Yes, the pharmacy department generates more funds than any other department in the hospital. More than 80% of patients who visit other service units in the hospital usually exit via the hospital pharmacy department. Now, in spite of the obvious economic and therapeutic importance, the government and many of the hospital boards do not accord the pharmacy department the recognition it deserves for reasons not understood. Pharmacists are not consulted when a new hospital is being constructed. The pharmacy department requires a certain amount of space for each service. When the hospital building is completed, pharmacy department is shown inadequate space area for each services. Government allows some hospitals to be run without pharmacists being in charge. This happens very often in private and mission hospitals. And this may be interpreted that the pharmacy is not a major healthcare provider. And at this level of our education, training, and the preparedness to offer clinical services, this type of situation should not be acceptable. And that they have stated that the Association of Hospital Pharmacists must bring to bear on the Ministry of Health for the need to have adequate infrastructure, complement of staff, and allow pharmacists to offer clinical pharmacy services in the hospital with the focus to improve patient care. And there should be high rating standard for accreditation of hospital pharmacists, especially those in the teaching hospital and federal medical center where clinical pharmacists should be trained. Pharmacoeconomics is part of operational research or drug use studies. It is apparently becoming important. Now, the use of some drugs, either alone or in combination with respect to cost and benefits, are not being evaluated. Stakeholders, government, NGO, insurance companies, and even individuals would like to know the benefits versus cost of drugs and other pharmaceutical products. As a result, some basic questions as outlined may be required. In a hospital, in other words, in a hospital, you may ask, do you have hospital formulary? Who are the members of the committee or hospital formulary? Is the pharmacist the secretary of the committee or hospital formulary? What procedure do you use to put or include a drug in the formulary? Does the manufacturer give you specifics under whose situation to use certain drugs? Is there any specific formulation for different types of patients? What is the procedure for delivering certain drugs to patients? And how do different patients pay for different administration of certain drugs? And for drugs to be disposed of, what is the procedure for disposing of certain drugs? These are certain questions that need to be asked, to be evaluated. The pharmacy has the responsibility of identifying therapeutic options, their costs and possible outcomes. The economic evaluation are important for making proper choice where there is an alternative users and resources. Alternative source is not a different manufacturer. Alternative choice is why this drug is better than that. Why should a patient use this instead of that? That is what makes the difference between a clinical pharmacist and consultants. Now, they're making proper choice where there's an alternative users and resources. The economic consideration is becoming important. The cost of drugs, some are more expensive than the other. So the economic consideration is important for the new roles of the pharmacist and the increased demand of the society. You go to this pharmacy, they sell you something for 4,000. You go to another one, 30,000. People will go where they're getting the cost cheaper. So cost effectiveness is becoming important, and we should not ignore it if we want to make profit. The pharmacist should realize now that his future survival, I repeat, the pharmacist should realize now that his future survival depends on interprofessional expansion, where he uses technicians to do traditional roles while he performs clinical functions. These new roles that ensure better patient outcomes include, inter alia, influence on rational drug therapy, selection of most appropriate drug, preparation and dispensing of the right drug, and so on and so forth. And each of these items have been properly discussed in the literature. Failure or lack of medication monitoring will lead to prolonged illness, suffering, and increased costs. Parameters for monitoring effectiveness of drug therapy and diseases are drug and disease dependent. However, pharmacokinetic monitoring of drug therapy has been an important advancement, and especially important with drugs that have narrow therapeutic windows. What will sustain the pharmacy profession is service and not drugs. I will make that what sustains the pharmacy profession is service and not drugs. Many people are selling drugs. Anybody can go anywhere and buy drugs, but service is the key. That's what I'm trying to emphasize. And that service comes into the clinical practice, the difference between you and somebody who is a chemist. If somebody goes to buy a drug in a chemist and a pharmacy, is there a difference? That is the service, and that's what makes the difference. So drugs are the medium for service. It is through clinical pharmacy practice that essential service can be rendered to the sick. With increasing cost of health service, health professions, including clinical pharmacists, have been called upon to costify their service. If we are going to offer clinical services, can we cost justify it? Pharmacists have been advised to document the values of any non-product centered service. We are going to implement clinical pharmacy. Is somebody going to pay for it? It's going to just be free for free. Somebody comes, you cancel him. When a psychologist talks to somebody, what does he pay? Does he give me anything? When you hire a lawyer to go and talk, does he give you anything? So why is it that when a pharmacist talks to a patient, he should not be paid for his professional service? It is this service that we must insist that patients pay for. And we're going to put it into the regulation that if a pharmacist does this and does that, if a pharmacist monitors a renal patient, advising the doctor, drug that is dilazable and those not dilazable, he should be paid for it. That is the point I'm trying to make. MC, you don't stop a professor when he's talking until he finishes. Anyway, now, establishment of clinical service. Pharmacists who want to offer and label as clinical pharmacists should establish such service in their choice in the institution. If you want to be a clinical pharmacist, you are going to establish that service. Such service unit may include drug therapy, monitoring, drug information, pharmacotherapy in various units of the hospital. Drug therapy monitoring involves the use of standard patient profiles. On approval, it must belong to a medical team whom that you make rounds with. You must deliver something that somebody is going to accept. It's not that you're just talking, you must do it. You join a program to be accepted, you join a medical team, and you are prepared to offer some consultative service. So clinical training pharmacists with experience should be attached to, e.g., pediatrics, oncology, ICU, cardiology, diabetic, renal, any of these areas you have trained yourself, you think you could be used, as well as provision of emergency medication services. If you go to many of the hospitals here, there are no emergency drug box. There's no hospital or clinic in the US, you will go and say clinical pharmacy, there's no emergency drug. There's emergency drug for so many things. If there's cardiac resuscitation, the heart attack, which box you bring at the budget is the pharmacy that is responsible for that. So do we have emergency box in our hospitals? So those who are going to practice clinical pharmacy, you have to read and open your eyes and establish the service. And those services, you have to take it through the administration of the hospital and let them approve of it and then get it implemented. And if you do that, I mean, there should be remuneration for your service. And without some of these services, my friends, within the medical team cannot influence, and you cannot be regarded as an integral member of the health team. Clinical pharmacy service requires, please, my friends, clinical pharmacy requires a lot of personal commitment and hard work. A pharmacist who wishes to offer clinical service must have positive, friendly attitude. I must have a good rapport. They are not, listen, doctors are not your enemy. Our enemy is disease, heart attack, cancer, and all that. So there's a certain point that you have to make clear to them. I know what I went through. I used to talking about Philadelphia. See, we know the opposition we had it there, but they had to see a way to find it. Make consultations, saying drug interaction, this and that. That's not the answer to it. You have to document some of these things you are saying, you are telling a doctor. Is it doctor in your own special area? If you are a clinical pharmacist in cardiology, it means that you are specialized on the literature that has to do with cardiac drugs. Therefore, you're in a position to advise a doctor on cardiac drugs. But if you're not a clinical pharmacist in diabetes, the new drugs that are coming up now, you're not current with them. You have to be current, be specific, get the information that is specific to the information. And that is how we are saying clinical pharmacy can be as simple and as complex, if complex that involves use of in other words, use of public information that this thing happens. So the pharmacist who wishes to offer clinical service, as I said, must be positive. And he has to ask some of these questions. One, do I want to practice? If you want to be a clinical pharmacist, you want to be in renal unit, ask yourself these questions. Do I want to practice the service? Two, do other health professionals want you or will admit you to practice it in the institution? Number three, do I have the required ability? Are there some remedial courses or remedies that I need to take in order to be effective? If I do, question is it worth the effort? You want to be clinical pharmacist, you want to do this. Is it worth the effort? Because you have to be on your toes. In any medical team, there are many doctors from various areas, and you are the only pharmacist in that team, and you're going to talk to them. My friend, you must have your onions very well, because you tell me you're a clinical pharmacist, to tell you some doctors who are really on their toes, know what is happening in all the journals. And maybe you're not reading all the journals. All you know is about. We have to prepare ourselves. That is the key point I'm trying to make. So, another question you ask yourself is, what are the social and professional and personal benefits to be derived from this service you want to offer? You want to go to oncology, cancer patients? Yes. There are specific guidelines and duration of administering cancer patients by IV, how many times? So you can be very useful in that unit. Many ways of administering and what advise the patient about cancer drugs, combinations. So if you want to do that, you're going to center on a lot of the cancer drugs. So you ask yourself, well, is the service cost beneficial and cost effective? Is it beneficial? Is it cost effective? Can somebody pay for your service? If we include it, now you're on renal patient, so can somebody pay for it? Final question you may ask yourself, is the society prepared to pay for the extra money? These things I'm saying, they have to go to some legislative level. It's not you alone, the society, PCN, CPAN, and other. We come and articulate, do some studies, and then present to Congress. Try to convince them that this is the type of pharmacist we want. And if they do this, okay, let me just tell you a story. The story is how the clinical pharmacists start in America. American Pharmaceutical Association did a study to find out that clinical trained pharmacists will save Americans so many millions of dollars each year. They convinced Congress. Congress, in being convinced, forget about other people. Congress convinced and gave what is called capitation grant. The capitation grant meant that for all of us who are pharmacists, who are introducing clinical pharmacy, the government will give you this amount of money. Those who are teaching will get this amount of money. Those who are being trained will give you this amount of money. When I went to Philadelphia, I did not pay a copy for my clinical training. It was as a result of capitation grant. So this year, these are ways we have to do some studies, we have to document. Having said that, I want to comment on need for training. There is great hope for clinical pharmacy practice in Nigeria, full stop. The education system has gone from 5 years B.Pharm to 6 years program, with many clinical courses have been added and taught. This is the right way to start. However, we lack the clinical training. At the moment, we do not have adequate clinical pharmacy staff to train our students. Training here means that the pharmacy student should be educated side by side with the medical and nursing student, where possible, in a teaching hospital. In training, clinically, you as a student, you see, you touch, you feel what other members of the health camp, what they see, what they touch, what they feel. And you have to do this. Not only one case of heart failure or one case of hypertension. It has to be many cases, rotating many units for several weeks. That's why I call it residency. You don't get residency experience by one day of a case. That's why immediately doctors finish their anatomy and physiology, they start training. So we need some training and a brief training for us to get the clinical experience so that we know what we're talking about with drug therapy. Now, the level of clinical service expected and practiced elsewhere requires high level of competence in practice. Involvement in clinical practice means more responsibility and therefore liabilities. And as a result, those who wish to practice clinical pharmacy must be ready for additional responsibilities. This requires additional training and demonstration of competence. Having upgraded to PharmD level, we need then to establish clinical clerkship. Furthermore, we have to introduce residency and fellowship training program in the teaching hospitals to acquire the required experience for clinical practice. So from the foregoing, it means that we cannot wake up one day and see clinical pharmacy in the hospital world without doing anything about it. It's not possible. It takes some time and effort of professionals with vision. Our pharmacists in our teaching hospitals and federal medical centers, they are working very hard. We appreciate their limitations, including non-cooperation from other members of health team, lack of infrastructure, inadequate sponsorship for overseas training. And I think the Association of Hospital Pharmacists needs to do more to establish clinical training and practice in their institution. PCN has worked very hard to introduce clinical pharmacy education in the 6-year program. But I would recommend a commission to study the overall pharmacy education and practice in Nigeria. I hope the outcome of such study will include standard of education, practice, and the practical needs. The PCN, the Association of Hospital Pharmacists, should work together with the Ministry of Health to create an enabling environment for clinical pharmacy in Nigeria. So in my conclusion, as you're expecting me to conclude, is that, that the sales pharmacy deals with patient and pharmaceutical products. As I have stated below, every pharmacist in Nigeria is practicing clinical pharmacy, either in the community or in an institution setting. The main difference is as simple as it is complex. It appears that each pharmacist is practicing at his level of acquisition of training and competence. Nigerian schools of pharmacy have made a giant step within 50 years to move from 4, 5 to 6-year program with introduction of clinical courses and then departments. With adequate manpower in academics and appropriate hospital facilities, we hope to train those who competently we claim to be clinical pharmacists. In addition, there are many bridges to cross, which include physicians' acceptance of the pharmacist's role in healthcare, government accommodation, and financial support for creating the environment for clinical services. Societal needs and cost effectiveness must be quite convincing to the hospital administration. It is going to take some time to occur. If it happened in some other countries and clinics, I do not see why we should not succeed in a profession that is traditionally clinical in nature. It must be realized that offering high-level clinical pharmacy practice depends on acquisition of new and lifelong learning. Thus, your mind will be kept perpetually open, like a parachute that functions when it is open to limitless possibilities. You must not be boxed in and think about pharmacy alone, because many things and skills that will make you succeed in clinical pharmacy are not found within the walls of the classroom in which we taught you. Therefore, additional training and skill acquisition are essential to prepare you in what you want to be and practice as clinical pharmacists. Thank you very much for listening to me.
Sounding round of applause for our father, Professor C.N. Aguwa. We can do better than that. A master class, enriched with so much wisdom, veteran experience in a purest form. Thank you, sir. Thank you. Thank you. I'm sure he didn't mean to interrupt you, sir. He couldn't have. We cannot interrupt you, sir. Thank you. We'd like to respectfully invite the national chairman to please come forward and make a presentation to our renowned father. Let's give him a round of applause as he comes forward. Clinical pharmacists, are we happy? Are we enjoying ourselves today? Thank you, National Chairman, sir.
Thank you very much. My dear colleagues and our guests, I want to thank our father in clinical pharmacy. Of course, I know all of us are with the brochures, and we saw 4 founding fathers of clinical pharmacy in Nigeria. And he is one of the founding fathers of clinical pharmacy in Nigeria. We also have another one, Dr. Arigbe Osula, who is also a founding father of clinical pharmacy in Nigeria. Our national pledge says that the labors of our heroes past shall never be in vain. Their yesterdays they gave for our today. I'm very happy that we have them. At least we still have about 2 of them alive. And I remember my lecturer, Dr. A.A. Oditola, at this moment. I pray that his soul will rest in peace. I also read about Dr. Fred Adenika, a one-time Pharmacy Council of Nigeria chairman. How I wish both of them are alive at this moment. The seed they planted, they started clinical pharmacy in the universities. Today, we are not talking about clinical pharmacy as such, but we are talking about association of clinical pharmacists in Nigeria. Nigeria, being the giant of Africa, is the first to establish this association. And I must say that forward ever, backward never for CPAN. Please permit me to, at this moment, my classmate is here. Air Commodore David Babalola is here. He will come to this stage. And I want to be fair to our mothers. Professor Femi Oyewo will come to the stage. I want to recognize Americans. We are clinical pharmacy started. And we have Dr. Anthony Ikeme from all the way from United States of America. I would like him to be on stage. I would also like to have Dr. UNO Waga. Okay, I understand. But then the president of the Pharmaceutical Society of Nigeria also has to be here as our father. Thank you very much. CPAN Board of Trustees Chairman, you are still needed, sir. You hand over to our paraphrase.
The president of PSN, the other time you were bragging, see my teacher, you pointed to Professor Femi Oyewo. You think you are the only one that has your teacher. See my teacher. For those who don't know, who think that I know anything in clinical pharmacy, he taught me, he baptized me into clinical pharmacy, and Dr. Ribosula confirmed me to clinical pharmacy. And that is why today I have been anointing disciples of pharmaceutical care, courtesy of my teacher. So, sir, it's my honor and pleasure on behalf of CPAN. This is just a symbolic award to appreciate. Honestly, when you came on stage to talk, I thought we are going to get you seated. But the energy with which you presented your speech, many of us who claim to be younger couldn't have done better. So, all we can ask is that the good Lord will continue to strengthen Professor Aguwa. Yeah, so that, you see, people sow seeds and they don't know if the seeds will germinate or if they will grow. But you have continued to watch that the seeds you sowed some years past are now growing. So you continue to live in good health and continue to see the profession of pharmacy, and in particular clinical pharmacy, to move from strength to strength. So on behalf of all of us, your children, your grandchildren, your uncles and your cousins, we make this presentation to you, sir. Okay. Thank you.